everybody. Welcome to the breakout session about GRIN symptoms. I will be your moderator for this session. My name is Liz Marfia-Ash, and I am Lucy's mom. Lucy has GRIN 2B. I'm also on the board of directors for GRIN 2B Foundation, and I am very honored to participate in this panel today. So we're just going to dive right in. We have Dr. Tim Benke from University of Colorado. We have Dr. Johannes Lemke from University of Leipzig, Germany. And then we also have Dr. Jennifer Bain from Columbia University, and she's with Simon Searchlight. And then we also have Curtis Weaver, who's also with Simon Searchlight. And just as a reminder, if you have questions, put them in the Q&A, and we might answer a few questions in between sessions, and then we'll get to as many as we can at the end as well. So with that, I'm going to turn it over to Dr. Benke.
Great. Can everybody see my slides? All right. So thanks very much for the opportunity to talk today. So I'm going to talk to you about the GRIN variant patient registry that we started at the University of Colorado, Children's Hospital, Colorado, in collaboration with Steve Trainellis's group at Emory. So these are my disclosures, and this is where I think we are with GRIN disorders to some degree, and I think parents may feel this way, as well as researchers as well. But our goal is to get here. And the hypothesis is that if we know the effect of mutation on GRIN function, that we can make sense of all of these symptoms, and therefore that we can come up with some rational therapies. So GRIN phenotyping, why should we make a patient registry? So as a parent, I think some of the questions are, what can I expect for the future, and what are the best therapies? As a physician and as a scientist, we're asking, can I predict the future based on your specific change in GRIN? Which mouse models should we make? Can I predict the future based on the functional change of the GRIN? Can I predict the best therapies? What symptoms do I try to target in a clinical trial? How do I measure those symptoms in a clinical trial? In other words, which clinical outcome measures should we use to follow in a clinical trial? So as the FDA or the European Medicines Association and industry, the sort of questions that they're going to be asking is this a unique disease with real symptoms? What are the patient numbers? Are they interested in organized patient advisory groups? Is there natural history data? Are there appropriate clinical outcome measures? In other words, they don't want to allow a trial if you're not going to get to any sort of meaningful outcome. Are there interested companies or scientists willing to pursue clinical trials? And what are you going to use? New drugs versus new indications for old drugs. So what are the GRIN features to categorize? So of course you want to know the GRIN change, and then we want to know how that specific change affects GRIN function. And the aspects that we want to capture with the registry are developmental milestones, whether there's regressions, how things change and improve over time, epilepsy, vision, movement disorders, growth, puberty, medications, therapies, sleep, behavior, GI, autonomic, and other illnesses and longevity. So our initial approach was part of our initial funding from CURE, which is Citizens United for Research in Epilepsy, with Dr. Trainellis. He was the PI on that grant. And we had funding through September of 2019. And we developed a questionnaire to capture features. We called it the GRIN questionnaire. We had approval from an investigational review board. And this questionnaire was put into a database format. And then our approach was just find, consent, enroll, and collect as much data as we could. Over this last year, to update our approach, we have had funding from GRIN 2B through, this now is through October of 2020. And as part of this last year, we've developed better partnerships and synergies with Dr. Lemke in Leipzig, Dr. Bain's at Columbia, and Simon's Foundation. We've updated the GRIN questionnaire to match the data collection from Dr. Lemke. And we've also updated the GRIN questionnaire to better reflect parental concerns. And this is through feedback from folks at GRIN 2B Foundation and at Cure GRIN. And now we've updated the consent form to allow de-identified of data sharing to our partners, to allow recontact for future studies. In other words, if a clinical trial comes along, we want to be able to contact families to bring them back in. But we've also updated the consent to allow contact information sharing with our patient advisory groups, GRIN2B Foundation and Cure GRIN. And we also want to start collecting annual updates. We're waiting on our IRB to approve this, but we're carrying on data collection with our current forms. Our overall goal across our sites is we want some joint papers that combine our data, and we want to start preparing these in 2021. So where are we with our patient collection? We've had 141 contacts, and some of these we're still awaiting return consents, or there's mixed and other genetic results, and so we're not necessarily including them here. But we have over 109 total consented patients. We've done well. This is now 55 just since September of last year. So big thanks to GRIN2B and everybody else for getting the word out there. We're still awaiting a number of people to return their GRIN questionnaires. We now have functional data on 73 of these different variants. Those patients that have deletions or duplications, we're inferring what their functional change is. And out of these patients, we've documented 17 different NMDA receptor drug exposures. So these are patients who are using magnesium, or ketamine, or memantine as part of their care from their physicians. And this is something that I really want everybody to notice is the number of patients with GRIN variants in the population. We need you. So this came up with some of the discussions earlier today. But basically, based on Dr. Lemke's data, we expect that there should be a lot of new diagnoses every year. And depending on lifespan, there should be 5,000 to 20,000 patients with GRIN variants in the US. So there are patients out there, we just need to find them. So in summary, we are capturing the clinical features that have been noted in the prior studies from Dr. Lemke, that we're able to capture them. Our key limitations are really reliance on the parent completion of forms. We've noticed that EEG and MRI reports are infrequently returned. We do need more patients to enroll. The patients must be out there. We're aligning and synergizing our collection across registries, and we're going to do further analyses pending more enrollment. Our challenges is how to get families to send in the genetic reports. We need both reports from patients and their parents. How to get the families to agree to participate in return forms. Huge thanks to Liz at GRIN2B Foundation for those incentives that she's been providing. And if you're already enrolled, please contact us to do an update. And we can help you pull some of those records for you if you can just send those to us. And of course, always there's the challenge of how to continue to fund the work. Special thanks to our patients and families, our partners, Steve, Scott, Hongji, and CFERB, Johannes, Jennifer, GRIN2B Foundation, and Cure GRIN. And this is the money slide right here that we want everybody to see. We want you to sign up, return the form, send us an update. All of this is on the GRIN2B website, and there's going to be an update just to make sure that things are super clear to everybody. But there you go. So I'll go ahead and jump off so that other people can tell you more about the registries. Oh, super, Liz. She's got it right there. That's great.
Okay, thank you, Dr. Benke, for that. So yes, I think there's lots of chat in the background in the Q&A and in the chat about where we can sign up for the study, and you answered that in your slide. So if you weren't able to take a screenshot of that slide, I did put in the chat, and I can go into the Q&A and put it in there as well. There's a link to the website, GRIN2B.com website, which has the information on the GRIN registry, and Dr. Benke did just send me some updates to make. I haven't looked at them yet, so I'm hoping they're somewhat minor. And then you can just email this Jennifer Sargent. I put her email address in there. You have to contact her first to start the process and make sure you know, she has to check your, I think, genetic report results first before you get the form and start that process. So I think we'll move on to the next one. Oh, I see lots of questions. Okay, well, I'll look through these questions. I might be able to answer some of them. But let's move on to Dr. Lemke. Go ahead.
Yeah, thank you very much. I'm talking about a few similar things as Tim Benke earlier, but we have a similar database, but it's a bit different approach. So let me show you. I'm not moving my slides on my own because I had some technical difficulties. So next slide, please. Thanks. We are a team in Leipzig. The members of our team are Konrad Platzer, Vincent Strelo, Ilona Kai, and me, who are focusing on GRIN research in our institute. Next slide, please. And we collected several cases in a database in the past years. Next slide, please. So far, we do have a few hundred cases with GRIN disorders, 250 cases with GRIN 2A, more than 100 GRIN 1, and more than 100 GRIN 2B cases, and just a handful of GRIN 2D cases. Next, please. And what we learned from this data that we collected from several international collaborators and from published cases that were published in the medical literature, we could see that there's a clustering of variants. You can see in the middle, next click please, that there are two regions where actually nearly all pathogenic variants are located. And on the right, you can see that there are many black bars on the bottom. That's the variants of, that are found in healthy population. So there are regions in the gene where there are lots of genetic variation in the population. And there are regions in the gene where there are basically not many variants in the general population, but most of the pathogenic variants in the patients. Next, please. And that's, next again. And that's the same situation for GRIN 2B as for GRIN 1. And we haven't looked onto GRIN 1 for the moment, but I'm quite sure that it will look quite similar. And what we found also is that there are some variants, or most of the variants actually, are unique. So there's only one patient so far that carries this particular mutation. And there are some variants that are recurrent and are being found in several individuals. And there are only very, very few variants that have been identified in multiple individuals. Let's say more than 5 or so. There's just a handful of that. Next, please. But I want to talk a bit about the phenotypes. In picture A, you can see the severity of intellectual disability in GRIN 2A patients. That's a recent publication of our group. And the blue part is the most interesting one, because you can see there that more than a third of the patients have a normal intellectual development. And there are several cases with mild or moderate or severe or profound intellectual disability, but a large fraction is normal. And if you look in picture B, then you can see that actually more than or nearly 90% of the patients have epilepsy. Picture C, more than 95% of patients have EEG abnormalities. And picture D is that more than 92% of patients have speech abnormalities. And that's a bit surprising, because you can see that you can have a normal intellectual development, but still have epilepsy, still have EEG abnormalities, and still have speech abnormalities or language abnormalities. Next slide, please. And we looked at a few of these issues and compared this to the other GRIN disorders. And here you can see again that actually GRIN 2A disorders are the only spectrum of disorders in the GRIN genes where individuals can have a normal development. In all the others, GRIN 1, 2B, and 2D, actually most of them, if not even all of the individuals, have a profound intellectual disability. Next. And the two next as well. We show all the 4 tables right away. You can see the speech impairment that is found in actually all patients. It looks like GRIN 2A has loss of speech impairment, but if you have in mind that all the GRIN 1, 2B, and 2D individuals have severe or profound intellectual disability, then they of course have also speech developmental delay. So everyone has a speech abnormality, but still 92% of GRIN 2A individuals have an abnormal speech, even though 38% are normally developed. With regard to seizures, you can see that 50 or 80 or 70% of individuals have seizures. There's one particular seizure type called epileptic spasms, or ES, that is frequently observed in all types of GRIN disorders, most frequently in GRIN 2B and GRIN 2D as well, but evidence is lower there. And it's rare in GRIN 2A, but it's also there. And movement disorders are also frequent, and there's one peculiar specific movement disorder called oculogyric crisis, which is an involuntary movement of the eyes, which has only been seen in GRIN 1 patients. Next, please. And the next as well. And there are also, yeah, you can see that all patients with developmental issues, they often have also hypotonia, so a muscle weakness, especially if they have a severe developmental problem and delay. And if you look at the MRI, then you mostly find nothing or unspecific findings like cortical atrophy, so something like a volume loss of the brain. But in very few cases of GRIN 1 and GRIN 2B, you find a very peculiar type of malformation of cortical development. That's brain malformation. The next slide, please. You can see that in the first line marked with the white arrows. You can see that the folding of the brain is much more detailed and smaller than it should be. This is called polymicrogyria, and also the inner spaces of the cerebrospinal fluid are widened. The first picture is normal, and the 4 pictures on the right are patients. And then it's in the second row, you can also see in the first picture a normal image, and on the 4 others, there's a structure marked with an asterisk, which is a spot called basal ganglia, which is enlarged in the patients, and it's also a bit more blurry than it should be in the normal MRI of a healthy individual. So this is a very specific brain malformation that is not seen much in other children other than GRIN 1 or GRIN 2B. There are some other genetic forms that have some similarities to these brain malformations, but that's very rare. Next slide. And what we did and aim for is this registry that Tim Benke also talked about just a few minutes ago. We have different approaches, and we are not in competition, we are complementary. So we have an online questionnaire, which you can find on the links that I showed you there. Unfortunately, currently it's embedded in our German-speaking homepage, so everyone who's not too familiar with German may have difficulties to find it. But you can see the links there, and we will translate our homepage sooner or later into English as well. Anyway, on the next slide, you can see that if you enter this registry, you have a form where you are asked to enter some contact information, and a second form where you are asked some questions regarding the consent of data usage and data sharing. And on the next slide, you can see that you are asked information about the mutation that has been found in the individual. Next, please. And then there are other aspects of the history and some more clinical details that you're being asked. And if you click through this questionnaire, don't worry if there are questions that you cannot answer, then just leave them blank. We are interested in any information that we can get, but if you cannot answer, if you don't know, then just leave it open. You can come back to this your entry at any time you would like and complete or add or adapt your entry. And yeah, that's what we are aiming for. On the next slide, you see actually a few people of the core team that is working together. Steve Tronelis in Atlanta is doing the functional investigations of the variants, and Tim Benke and I are looking for the phenotypic informations. And you have seen in Tim Benke's talk already that Tim Benke is actually collecting all the patients from America, North and South, as well as Australia. And due to his IRB, there were difficulties in collecting European patients. So that's what we do now in Leipzig, in Germany. We try to collect everyone from Europe, but also from Asia and Africa. So we divided the world a bit into two parts. And you should not register in both registries. Please only use one, because in the end we are working together, and we made sure that the questions that are being asked are compatible and that we can fuse the data in the end. So don't worry. And if you have any questions regarding our registry, the email address is written below, and thanks for your listening. Now that's for the next talk then.
Thank you, Dr. Lemke. Okay, so we've had lots of questions in between about mainly just about the links and technical questions about translating into languages, and it looks like everything's been answered. I'll keep scanning through. Thank you to Dr. Park for answering so many questions. And so next up we have Dr. Jennifer Bain from Columbia University and Simon Searchlight.
Hi, can everybody hear me okay? Okay, so you can hear me, I just can't hear you, but that's fine. All right, so hi everybody, thank you for having me. I'm here today, I'm a child neurologist at Columbia University, but I also help work with the Simon Searchlight initiative. And so I was explained to provide complementary data support and phenotyping as opposed to competition. So hopefully I can go through our information. And if because for some reason I'm in poor Wi-Fi and I don't want my audio to chop out, but I'll pop back on right after. Okay. So just tell me when you can see my screen. Right. So today I am representing Searchlight and explaining information that have been collected from the GRIN2B data group. The goal of Simon Searchlight, this is a nonprofit arm of the Simons Foundation, and the goal of this organization is to collect detailed medical and behavioral histories, along with biosamples, such as blood and saliva samples. The goal overall is to synthesize this information that you provide as families, and then be able to share these families back to families so that families can see what information as a group is collected. Furthermore, the goal of Simons really is to freely share this data and samples with qualified researchers. And along these same lines, Dr. Benke and Dr. Lemke and Dr. Tronelis have really been working closely with Simon Searchlight to align these data collection efforts together. The overarching goal of Simon Searchlight really is to connect participants from around the world with these extremely ultra-rare disorders, and to really provide a better understanding of what these genetic changes mean and moving forward. Simon Searchlight actually has changed quite a bit. It's been in process for almost a decade now. It originally started in 2011, in which case a single genetic change was being studied. And at that time, all the families that had that single specific genetic change traveled to study centers. They provided all of their information to researchers. And however, it did so well, and they've done such a fabulous job, they've taken the same initiative for other genetic changes that are associated with lots of types of neurodevelopmental disorders. And today's Simon Searchlight has over 100 different genetic changes that's available to both families and researchers. One of the greatest things that Simon Searchlight has already been doing over the last few years really has been to provide this data support and data collection from being in the convenience of their own home, which obviously in today's era is really critical. When an individual gets enrolled into the Simon Searchlight registry, similar to the other labs that you heard about earlier, the genetic report will be provided. And typically it's the genetic report from that individual's, as well as parents and siblings, if that's been collected as well, to assure that that individual does in fact have a problematic or pathogenic change in that specific gene. After that time, there are different approaches. As you heard earlier, some approaches have been on the phone, some approaches have been online. Simon Searchlight uses a combination of both. After an individual is enrolled and consented into Simon Searchlight, and they provide their genetic reports, after that, there's a phone interview in which typically a professional in Simon Searchlight will go through all these medical history questions, as well as obtain information from an adaptive behavior scale called the Vineland. And after that point, they will be provided lots of different options for different online surveys, such as seizure histories, medication histories, and other types of background and behavioral checklists. What's really great about Simon's is that they do collect data longitudinally, and so every year they will reach back out to families and obtain that information on an annual basis, which really gives us a great idea of what happens to individuals when they enroll and as they get older. So the wonderful thing is that I came and I met most of you last year, and everybody's done a really great job in seeking interest and enrolling in Simon Searchlight. And while GRIN 2B was the first group in this GRIN community to come to Simon Searchlight and enroll, the other GRINs have come forward and have enrolled. Luckily, GRIN 1, GRIN 2A, and GRIN 2D have all started enrolling in the Simon Searchlight project. However, there's not just enough information at this point that we can present safely in a de-identified safe manner. And so hopefully I can encourage everybody to continue working with Simons and signing up. So today I'm only going to be presenting the information from the GRIN 2B registry. So as I mentioned, at first, an individual has to just email or call, Simon Searchlight just to get started. And so over 100 individuals have actually registered. So you took that first step. And without you actually reaching out to us, we can't come to you. So thank you. About half of those individuals have been able to provide their genetic reports, and they are indeed consistent with a pathogenic or problematic gene variant. And so that's great. We're getting there. 45 of them are pathogenic or likely pathogenic. And then 33 individuals up until just a few weeks ago have completed that initial intake interview called the medical history interview. And so today I'll be representing these 33 individuals, 14 of which are female, 19 of which are male, and this is ages 1 through 21. There are some additional participants who perhaps have lab reports that maybe there's a concern for a genetic variant, but we're just not sure 100% that variant is enough to be the only cause of their perhaps neurodevelopmental disorder. So we're collecting that information, and we'll continue to utilize that in our registry. I'm not going to go through the specifics here, but each one of these represents the different pathogenic or likely pathogenic variants. Dr. Lemke just showed you the specific locations of these typos in the genetic code. And as you can see, there are many different types of changes, whether they're typos or small deletions or small areas that are of the gene that are shifted around. These are all the different genetic variants that have been seen in the group that have registered. So this is a really important slide. A lot of people want to know what's going to happen to my child. And Dr. Benke said at the very beginning of this session that as a parent, you want to know what's going to happen to my child as they get older, and what do we need to do about it? How do we know what to expect for our child? Obviously, we don't have a crystal ball, but if in the setting of a rare disease, we can collect as many people as we can with this specific genetic disorder, and we can monitor them over time or see individuals who are older, that might give us a little bit of a clue of what to expect, or at least what's going to happen over time. What are things we need to watch out for? And so as you can see, the majority of individuals that have enrolled in the Simon Searchlight Project thus far really are little ones, so 1 to 3 years old, 4 to 6 years old. Importantly, though, we do have some individuals who are a little bit older. It's going to be so important for all these individual people to continue staying with Simon Searchlight, answering those phone calls and those emails, because as you heard earlier, keeping somebody involved in this type of registry is so important to understanding the future. And so you guys have a really wonderful opportunity where you capture all these people at a very young age, and we can watch them grow up and gather information as they get older. So I'm just going to go through some of the basic information from the medical history intake, again, of the 33 GRIN 2B participants. The majority of individuals here do present with developmental delay, so 82%. And this is typically where most of these individuals do end up getting their genetic testing in the first place. For some of the older individuals, they might have a diagnosis of intellectual disability. About 2/3 of the individuals do have some kind of language impairment, 2 of which, or 6%, have some what we would call minimally verbal state. There are individuals who have a diagnosis, a formal diagnosis of autism spectrum disorder, as well as a few individuals, 12%, who have attention deficit hyperactivity disorder. Commonly in other neurodevelopmental disorders, eye and vision problems are often seen in individuals. So this could include strabismus, or eyes that are disconjugate or not lined up correctly, or a lazy eye, sometimes people say, in about half of the individuals. Involuntary eye movements, as we heard earlier, that there are some interesting eye abnormalities. Cortical blindness is actually not a problem with the eyes themselves, but a problem with the brain understanding that vision. A few individuals are nearsighted, a few are farsighted, have astigmatism, a lazy eye, a depth perception, a drooping upper eyelid, or some other eye condition. In terms of other neurological disorders, again, this is what we call a neurodevelopmental disorder, so it's not uncommon that many individuals do have neurological issues. 97% have what we call hypotonia, or low muscle tone. They're very loose, very lax. That's 32 of the individuals. 10 individuals do have coordination problems, so motor planning difficulties. Spasticity, or high muscle tone, or tightness in those muscles, has been reported in 24%, or 8 individuals. As noted earlier, similar to the other groups, there 12%, or 4 people, have reported having a movement disorder. 3 individuals report having a larger head size than typical, which is called macrocephaly. Another 2 individuals have a small head circumference or head size called microcephaly. 2 individuals have been given a formal diagnosis of cerebral palsy, and 1 individual has a tic disorder. With regards to seizures, as we were hearing earlier, the different GRIN variants, some have more seizure burden than others. In this group of individuals, 6 people reported having seizures, and it was different types of seizures. A simple partial seizure had 2 individuals. 1 individual had a full body grand mal seizure. 1 individual had a petit mal or absent seizure. 1 had an infantile spasm, and 1 had a complex partial seizure. I'm going to get to the medications for that in just a few slides. With regards to gastrointestinal issues, another common problem in individuals with neurodevelopmental disorders. Reflux or heartburn was reported in 16 individuals, just about half. 14 individuals, few less than that, reported constipation. 2 had diarrhea, and 2 had other GI complaints. With regards to surgeries, 4 individuals in the group did report having a G-tube, or a supplementary feeding tube. 4 individuals have broken bones. 4 have ear tubes. 3 individuals have had an adenoidectomy. 2 of those probably also had a tonsillectomy. 2 have had eye surgeries. 2 have had a hernia repair, and 4 other surgeries as well. People often want to know, especially in today's day and age with COVID, whether or not they're at increased risk of infection. Based on the information we have here, about half of the individuals have reported having ear infections, which is about 20 individuals, and 5 individuals have pneumonia. It doesn't seem to be a particularly immunocompromised or immunosuppressed group of individuals. And this is also overlapping to that. 2 individuals reported having recurrent pneumonia, and 1 reported having another respiratory issue. With regards to growth and hormone being more of a systemic issue, 11 individuals have reported difficulty growing or gaining weight. 2 individuals have reported a short stature, being shorter than their typical age. 1 has reported having diabetes, and another with low thyroid or hypothyroidism. Bone abnormalities or musculoskeletal problems. 3 individuals have what we call a pectus, sunken chest. A abnormal curvature of the spine or scoliosis is reported in 2 individuals. A pigeon chest in 1 individual. A low bone density in 1, and 3 other individuals with other bone problems. We ask a certain subset of individuals, what medications are you taking or have you been taking? And so we'll present this information really briefly as well. 40% of individuals have reported being on some kind of medication to address GI or gastrointestinal issues. 28% or 7 individuals report having asthma or respiratory or allergy type of medication. Those 16% or 4 individuals are on medication for seizures. I'll tell you which specific ones in a minute. 12% or 3 individuals are on medication to address behavioral concerns, one of which has severe behavioral concerns. There are 3 individuals in the group who report using CBD, cannabis, or cannabidiol. 1 individual is on an antidepressant. 1 has been on medication for attention and hyperactivity, and another for pain. With regards to better understanding, as we mentioned earlier, the goal of registries is to seeing who responds to what medication the best. 19 individuals completed a seizure medication questionnaire. So this was within a seizure history survey. 2 individuals, or 11% of children, reported being on a medication called levetiracetam or Keppra. 1 individual has been on gabapentin. 1 has been on lamotrigine or Lamictal. 1 has been on oxcarbazepine or Trileptal. 1 has been on valproic acid or Depakote. These 2 individuals who reported being on levetiracetam or Keppra has been reported to have the most effective control for their seizures. On the other hand, other individuals with gabapentin, phenobarbital, and valproic acid have reported being effective for controlling their seizures. 1 individual has reported using medical cannabis or cannabidiol compound as being effective for controlling seizures, and 1 other individual does report being on a special diet called the ketogenic diet, which has been helpful for their seizure control. So in summary, this was based on the Simon Searchlight 33 individuals with GRIN 2B pathogenic or likely pathogenic genetic variations. The common issues in this group are developmental delay, language impairment, vision and eye problems, low muscle tone or hypotonia, GI issues, and some ear infections. The less common issues, but still are present, include autism spectrum disorder, coordination difficulty, difficulty with weight gain or failure to thrive, and seizure disorder. So we will definitely make sure that we provide information about how families can become involved in the Simon Searchlight Registry. And for those researchers, again, the important information to know about Safari is that this is free information as long as you are an interested and well IRB approved and institutionally supported researcher, and just signing an agreement with Simon Searchlight to safely use that information. Safari will freely share this information. Thank you for your time, and great job. This is really thanks to you. We couldn't present this information without families like you. Clearly you've done a great job from this year to last year to this year, and we really hope to continue to work with your family groups. Thank you. Have a nice day.
Great. Thank you so much, Dr. Bain. So we have a few minutes left for questions. I've been looking through and I see there's a question about susceptibility for COVID, and Dr. Benke thinks we should talk about that at the last Q&A session, which I agree. That seems like an important question that probably everyone's going to want to know more about. And then in general, I think we've answered the questions. If anyone has something, pop it in real quick. I thought maybe real quickly we could kind of review. So you don't have to email both Dr. Lemke and Dr. Benke to sign up. If you already have, though, I assume that's fine. I know, for instance, my daughter, I registered with Dr. Lemke, back in 2015, probably before I even knew about Dr. Benke, or I'm assuming before Dr. Benke was even collecting information. And now I've enrolled in Dr. Benke. So you guys have both have my daughter's information, but I'm assuming that's no big deal. But so if anyone has any questions about who to contact, I think Tim also said if you contact the wrong one, then we'll just direct you to the right place. But one thing I thought we could go over is, but Simon Searchlight, although you are all wonderfully collaborative and you guys all talk and you're buds now, people should still sign up separately for Simon Searchlight, correct? Okay. And then so I guess
so they are separate, but we are trying to combine as much information as we possibly can and make sure we're not being duplicative in what we're asking you to do.
Right. And so I guess, does any one of you want to quickly just say, I know we've talked about this at the GRIN conference last year and probably at the GRIN 2B conference the year prior. And I feel like we talk about this, but we talk about form fatigue and why do I have to sign up for all these different things? And anyone want to give a quick pep talk to why people should do as many registries as possible?
I seem to recall a very entertaining video put on the GRIN 2B website about why you should do it. Yeah, it's painful, and we appreciate that. And we know that you rather clean the floors instead of fill out another registry form. But this is the road that we have to go if we're going to get to nicely set up clinical trials and a good natural history and cures. So it's not easy, but this is what we have to do. But yeah, each registry, as Johannes and Jennifer was saying, what we're doing is complementary. We've tried to make things where they need to, they overlap so that you're only having to do one. But and we do have things in place such that if you've registered for Johannes and then you registered for us or vice versa, that we can still use that data so that we make sure that we're not counting people twice. I hope that answers the question.
It does. And I guess I'll just give a quick plug to the fact that there are incentives, at least at the moment, to join. I know Simon Searchlight always gives out Amazon gift certificates. Someone correct me if that's wrong. I know I got one recently.
Yeah, I believe that's right.
Yeah, I think it's depending on each questionnaire you fill out, you accumulate some sort of dollar value, I guess, and eventually they say, hey, you've got Amazon gift certificates. And then for right now, this won't forever, but those who enroll in with Dr. Benke or Dr. Lemke for at least through September, we might have to extend it through October. I know Dr. Benke, your form is still getting tweaked or approved by your IRB, but we will also be giving out $25 gift cards for people who complete that registry. So I think that's it. I don't see any more questions coming in unless I've missed something. I think we're about ready to wrap up. It's time to move on to the next series of breakout panels, which I will just tell you are, your choices are meet the NMDA receptor, or you can learn about the difference between GRIN genes, GRIA genes, GRIC, or GRID genes. They're a broader family of genes. And then there's also a Spanish meter. And these are basically starting, I think, in about 1 minute. So we are done. Thank you all for joining. This was really great. Thank you, Dr. Benke, Dr. Lemke, Dr. Bain. Thank you, Curtis. And I will see you all in the next session. Okay, thanks, guys.